go and I will try to share my knowledge in front of you all. I hope you will all will grasp the things, and definitely you will have another different experience in the clinical field. So we should start because already due to some network congestion we have less the time. My topic is physical assessment and clinical reasoning for cervical spine. Exactly what is the cervical spine and what is the neck pain? The neck pain is another word that is called as cervicalgia. Cervicalgia is a common terminology which is used in the medical field. Cervicalgia, it consists from the neck pain. Now, the neck pain problem is 2/3 of the population is in the India or worldwide. Mostly commonly affected person is adulthood. The adult person who is going to do work in their office because of their occupation, the pain is very common in the neck region. This is maybe because of any kind of cervical areas like soft tissue structure, like bony structure, like due to some vascular insufficiency, pain may be there in the neck region. In some studies, it is found that the 30% of the neck pain will develop chronic pain. So the chronic pain can be treated either physiotherapy or physical therapy, like conservative physiotherapy or surgical therapy. So it will be the part of neurosurgery. Now we will come to the our part. So it is anywhere in the cervical region or cervical region anywhere, like if you can see in this picture in the slide, it is either in the intervertebral disc, nerves, muscles, blood vessels, esophagus, larynx, pharynx, trachea, thyroid gland, anywhere in the cervical structure. It may be a cause of neck pain. Now, the neck pain is commonly seen in the females in comparatively to the males. So the ratio of pain is the increase in the females due to the bad or poor posture, due to some occupational hazards, due to some prolonged setting, due to some today's life, like everyone is busy with the mobile. They are giving their time more than 2 or 3 hours continuously in front of the mobile while flexing the neck. So that may cause pain. 2 or 3 months before, I have given an interview in the newspaper. In that newspaper editor, he asked the same question about the neck pain, which is common in the adulthood. Right. So, as a professional physiotherapist, our field of practice is neck pain. Neck pain includes soft tissue. The soft tissue is especially like muscles, ligaments, tendon, blood vessels, and the nerves. These are all soft tissue. Right. Like the bone region, bony and neck region. Bony and neck region like facet joint, intervertebral joints, and the disc. Disc also consists in the soft tissue structure also. Right. So in the upcoming slide, we will see the anterior and posterior soft tissue structure. Especially, we will see the neck muscles. The neck muscles, like these are the neck muscles which can be seen in the posterior side, like semispinalis, capitis, sternocleidomastoid muscles, splenius capitis, levator scapulae, trapezius. These are all common muscles which can be seen posteriorly, and these are all inserted in the anterior side also. Like we can see the trapezius muscles, like sternocleidomastoid, levator scapulae. What are these soft tissue structures works and how they works in the cervical region? So first we will discuss about the sternocleidomastoid muscles. It attaches to the top four vertebra of the like C1 to C4, and it runs down from the side of the lateral side of the neck and the shoulder. That is the levator scapulae. Cervical, like most common, that is the sternocleidomastoid. Sternocleidomastoid muscles it is inserted in the anterior side of the neck or frontal side of the neck, that is in the sternoclavicle joint, right? Like we will discuss about the trapezius muscle. Trapezius muscle, it is also the largest surface muscles. The trapezius muscles can be involved into the extending the head upward, like head upward, and the neck backward, and rotating. It helps to rotating the neck and turning the head, lifting the shoulder blade also, right? Now, the bony structure. The bony structure, it consists of so many structure like atlanto-occipital joint. Atlanto-occipital joint, it allows to permit the movement of nodding, right? Atlanto-occipital joint, like flexion and extension, it comes from the atlanto-occipital joints, and turning of the left side, right? Then atlanto-axial joint. Atlanto-axial joint with the C1 and C2. C1 and C2 joint. It comprises three synovial joints. One is central atlanto-axial joint and two lateral atlanto-axial joints. Now, the third one is intervertebral joints. Intervertebral joints means below the C2 adjacent cervical vertebra are linked by the intervertebral disc. That is the intervertebral joints. Now, the discs are for the restrain the movement, that are saddle articulations, right? Now, common causes of neck pain. The common causes of neck pain are anomalies in the bones and joint over the cervical region. So, anomalies which is more common in the cervical joints, it is anomalies. Then after trauma, this is maybe because of the sports, maybe because of the road traffic accident, maybe because of some kind of a sudden fall from height. Trauma can cause neck pain. Or in the routine ways, we are having a lot of traumas due to some stress, due to some muscle stress, due to some age related change or poor posture, that may have causes of neck pain, right? Some major and severe causes of neck pain, like carotid artery dissections. Now, what is carotid artery dissections? Carotid artery dissection is a separation of the carotid wall. This is it is a condition whereby the layers of the carotid artery are spontaneously separated. Because of that, patient may have pain in the neck. Now, the second is referred pain from acute coronary syndrome. Because of the acute coronary syndrome, in this condition, the patient is having insufficient blood flow to the heart. Because of that, patient may have referred pain in the left side of the arm, and sometimes he feels pain in the shoulder or cervical region. That may also correlate with the neck pain. If the blood flow gets obstructed, that may cause the infarction or cardiac infarction, MI, that we are also known as in the word of MI, myocardial infarction. The another causes, that is head and neck cancer. Because of head and neck cancer, patient is having some restrictions of the neck movement. Patient is having pain in the neck. Another cause is infection. Infection is retropharyngeal infection, abscess, epiglottis, some sore throat infection. That may also cause neck pain around the neck. Spinal disc herniation because of the protruding or bulging disc or severe prolapse. It is also causes the severe or major cause of neck pain. Now, spondylosis, which is very common nowadays, it is early age spondylosis seen in last few decades because of their daily routine or daily poor posture, right? Some degenerative arthritis or osteophytes may be seen in the cervical spondylosis. Another cause is spinal stenosis, a narrowing of the spinal canal. Because of that, patient may have pain in the neck. Some more common and lesser neck pain that can cause stress. As we all know that we people are doing work in the field, or a person is doing their work, because of their overexertion and sometimes because of their emotional stresses, patient may have constriction in the muscles, neck muscles, that may cause pain. Now, prolonged posture, as many people are sleep on the sofa, chair, and wake up with the sore of the neck pain. Sometimes patients may not use pillows or may not use any kind of a support, and that may be in a some wrong posture, prolonged lying down on the bed, that may also cause the neck. Some minor injuries like fall, as we have already discussed, like car accident, sports events and injuries, or day-to-day minor injuries, that may cause the neck pain, which is to be like negligible kind of a pain, which cannot be considered as a neck pain, because it is nowadays in our daily routine life. Now, referred pain. Referred pain mostly from the upper back problem. Because of the upper back problem or some poor posture, the patient may have a complaint of referred pain also. Some overuse, muscular strain is one of the most common causes. Overuse means the person is having continuous use of such devices and digital in this digital world. The patient's postural muscle gets contracted. Because of the contraction or because of the overuse of the muscles, the person may have pain in the neck. Now, the another one cause is herniated disc. Because of the herniation of the disc, patient may have a referred pain. Some sign and symptoms of the neck pain. The neck pain symptoms, especially like tenderness, swelling, muscle spasm, some stiffness in the neck, some kind of any kind of inflammation or infection may be there. Because of that, patient may have a fever, headache, or sometimes emotional stresses. Sometimes because of the muscle strain, patient may have, or because of the severe pain, patient may have vomiting, swelling over the gland in the neck, arm weakness, because of the neck, because of the herniation of the disc, patient may have a weakness in the leg also, and sometimes patient complaining of the bladder and bowel and inability to walk. Right. Now, the classification of the neck. The classification, it is again divided into three parts. One is axial, radiculopathy, and myelopathy. In the axial pain, the pain is musculoskeletal and it is purely or the neck area or soft tissue pain. This pain is not referred to your arm or your to your upper extremity. This is just a localized pain that is called axial pain. This is maybe because of the whiplash or any kind of a muscle strain. Now, next one is radiculopathy. Radiculopathy due to some cervical, due to some compression over the nerve root. The patient may have pain in the referred pain in the limbs, upper extremity, right? That may include arm pain, numbness, or weakness in the small joints, or weakness in the small muscles, right? Now, myelopathy. Myelopathy refers to pressure on the spinal cord, right? So, if a pressure or if a compression over the spinal cord, the patient may have weakness. The patient may have a neck pain. Along with the neck pain, patient may have a motor weakness, motor loss on the upper extremity, or some sensory loss or some sensory involvement in the upper extremity. Sometimes it may also have the problem in the lower limb also. Right. Now, clinical examination of the neck. For clinical examination, we will go through some examination like local examination of the neck with neurological examination, and then examination of the potential extrinsic source of neck symptoms, then general examination. We will go through these three headings, right? Now, first, we will inspect the patient. We will inspect the patient. When patient comes to the department or clinic, we will see is bony contour, any kind of a deformity, any soft tissue contour. Soft tissue contour, how we can see? We can see first when a patient comes in the department or clinic, we will expose the neck area, right? Then we can see, we can easily see the any contour of the spine. We will turn the patient, we will see the patient easily. Now, soft tissue contour like any kind of a swelling, over the neck area, we can see, we can inspect. Now, any changes in the color of the skin or any texture like is there any shiny skin or some kind of creasing of the skin that can be inspected, right? And any scar or any sinuses in the neck area that we can inspect very well while seeing the patient, right? Now, palpation. With the help of palpation, we can check the temperature of the skin. We can palpate. We can check by the dorsum of the hand. Dorsum of the hand. We can touch the patient's skin, and then we can check the temperature, either it is a normal or not. Then bony contour. Any kind of a bony contour, any kind of a bony projection that we can palpate the patients. In the next slide, I will explain. Now, soft tissue control. As I have discussed, as I have told you that any kind of a swelling that can be seen by the inspection, and that swelling can be feel by the palpations. And by the palpation, we can see the swelling, and while pressing the particular area, the patient feels some pain or tenderness over that region. A therapist is palpating a patient by his hands while touching the neck areas. He is inspecting the soft tissue and nuchal areas. Right. Now, we will examine the movement of the neck. Usually, the movement what we are seeing is flexion and extension of the neck, lateral rotation of the neck, side by side, and rotation, right? And the rotation. This is the lateral flexion, and this is the rotation. So, the normal range of neck flexion and flexion, that is 70 to 90. The extension range is about 70 degree. The lateral rotation, it is lateral rotation. Lateral rotation is about 70 degree, and the rotation, complete rotation, is around 90 degree. So we will feel the pain or crepitation during these movements. These are the lateral flexion and side rotation. Now we will go for the neurological examination of the neck. For the neurological examination, we will go for the muscular system examination. We will see the fasciculation or vesting and the neck muscles. Fasciculation is a kind of a thing which can, in which the person wants to perform the task and he is unable to perform the task while on that particular muscles is getting flickering, or because of the vesting, because of the muscle weakness, the person muscles is getting flickering of that particular reason, right? And some fasciculation may be seen due to vesting of the arm. Now, the sensory system. In the sensory system, we will find the dermatomes. We will examine the dermatomes and myotomes. So, dermatomes and myotomes. How we can see the dermatomes, myotomes? By checking the dermatomes. Dermatomes like upper extremity dermatomes starts with the C1. C1 is we can see the top of the head. Then C2 is side of the neck. Then C3 is the area of the shoulder, and C4 is the top of the shoulder. These are the C4. Then C5 is over the medial part of the upper extremity. Then C6 is lateral side sensory examination, like C5. Then C6 is lateral side of the shoulders. Then C7 is the posterior side of the arm. Posterior side of the arm. Along with that, muscular system examination, we will examine the biceps and triceps and brachioradialis. These are all the reflexes. These are the dermatomes and myotomes. Dermatomes, we can give the words, or we can recognize or remember very easily like C1, C2, and C3. C1 is oh my and God. Oh my God is a very common thing. Oh my and God. Oh my God, C1, C2, and C3. Then C4 is the shoulder area. C5, then C6. C6 in the C6, three fingers are involved. C7 is the ulnar area, and C8 or T1 is the our posterior side of the arm. Now, sweating. Sweating is the moist or dry sweating. This is a hypothalamic part. So, sweating because of any swelling or because of any kind of inflammation or infection is there, the sweating may be present or maybe there. Now, we will check the reflexes. In the upper extremity, we are checking biceps reflexes, biceps jerks, triceps jerks, and brachioradialis jerks. In the, we can see in this picture the tricep jerks that can be found in the lower insertion of the triceps. We just tap the hammer, and you will feel a contraction, sudden contraction or involuntary action of the triceps muscles, right? So this is the triceps jerk. Bicep, for the bicep jerks, we will touch, we will take by the like hammer. We will tap over the biceps tendon, and you will feel the biceps jerk while flexing the elbow, right? And again, another thing is brachioradialis. For the brachioradialis jerk, we can tap the hammer over the medial side of the arm, right, in the semi-prone position. Now, examination of the extrinsic source or neck pain. The pain may refer from another organ like ear or throat. Ear or throat, like any kind of a otitis media, any kind of a sore throat that may have a local neck region pain, that we have to differentiate by the clinically testing. Now, checking of the brachial plexus. Now, brachial plexus distribution. Sorry, brachial plexus distribution. It is also a consist of a bundle of the nerve, brachial plexus. So we will check the roots, branches, and another divisions. All we have to check properly. As we all know that brachial plexus is a kind of a topic which can be covered in an entire lecture also. Some another investigations, the investigation for the neck pain reasons, due to some infection, due to some inflammation, patient may have neck pain, so that we will go for the blood investigation or pathological investigation like complete blood picture, PSR, hemoglobin, CRP, rheumatoid arthritis, and some radiological investigations. We will go for through the cervical X-ray, then after CT scan or MRI, vice versa, right? So we will not go through this blood investigation. The important thing is X-ray. We will take X-rays. The X-ray especially we are taking in the routine ways, anterior posterior view or lateral. In the anterior posterior view, we are assessing, or we can assess or evaluate the lateral masses of the cervical region, equal separation of the spinous process. In the upcoming picture, I will show you. And the best view of vertical compression. If any compression or any fracture, then we can see anterior or in the epiview, or equal disc space we can easily judge. In the lateral view, we can find it the curvature of the spine, as we all know that the spinal curvature is lordotic curvature. So we can see the curvature in the lateral view. We can see the cervical vertebra, any cartilaginous or disc space, cervical suture, neural arch, lamina, spinous process. So many things we can see in the lateral view. I'll show the picture. Another one is swimmer's view. Swimmer's view and odontoid view. These are not very common views which cannot be advised in a routine manner. These views can be required while seeing the C7 and T1 area, swimmer's view, and in the odontoid view to see a dense or C2 vertebral body. So we can check by the help of odontoid view. I can explain you what is the Seamer's view. Seamer's view for checking the C7 and T1, right? And odontoid view for the odontoid view, the person should open the mouth, and the X-ray will take from the anterior side. When while opening the mouth, our C2 vertebra is visibly in the X-ray film. How? I will show you in a picture. This is the anterior posterior. In this anterior posterior view, we can easily find, yes, from here I will tell you, we can easily find this as the cervical vertebra. We can see start from the C4, C5, C6, C8, and C7. This is the black line. Black line, you can see this is the trachea, right? And intervertebral disc between two vertebrae, you can see, you can find the disc space. You can find the disc space. You can see the pedicles of the vertebral body. This is the number of vertebral bodies like C7 vertebra, C4 vertebra, and C7 and thoracic T1 vertebra, right? We can see the spinous process, but in the anterior posterior view, it is not very it is not giving clear information. So we will go for the lateral view. In the lateral view, we can see easily the posterior arch of the C1, right? The posterior arch of the C1, the articulating or facets like superior articulating and inferior articulating facet joints. Like these are the vertebral spine, vertebral bodies. These are the spinous processes. You can see very easily in the lateral view, right? And anterior arch of the C1. Dens is not visible in this lateral view. So for the dens, we will go for the another view. Like this is the swimmer's view. Now, swimmer's view. For swimmer's view is for the C7 and T1. In this position, we can easily find the C8 and T1A. Now, this is the odontoid view. In this odontoid view, this is the odontoid process, or we can see the dense area. If any kind of a fracture or any kind of a problem in the odontoid process, then we can examine by the odontoid view in a radiographical X-ray, right? This is the complete C2 vertebral body that we can see while opening the mouth X-ray, right? Some abnormal X-rays, like this is the degenerative changes X-ray. We can see this arrow. You can see these are the osteophytes. These are the osteophytes. You can find it in the lateral view. You can see some degenerative changes, some bony erosions over the neck region. These are the tubercular spine X-ray. In the tubercular spine, some shiny structure or some kind of a damaged vertebra, we can find it. This is the rheumatoid arthritis conditions patients. Its X-ray is showing some disalignment of the cervical spine and loss of curvature of the spine. We can see in this view. Now, the neck strain due to awakeness or sleep. While we are getting up from the sleep, we can feel sometimes pain over the neck. This is because of the poor posture or bad quality of our routine life. The patient may have pain in the neck. Now, neck pain, according to the onset, is acute pain and chronic pain. What is acute pain? Acute pain, it is occurs due to some injury or stress. Most of the time, it resolves within 7 to 10 days automatically, or by doing some rest, by doing some conservative therapy like icing or any kind of pain reliever medications, right? For symptoms that may persist longer than a few weeks, we can take a physical therapy or some kind of a dry needling or chiropractic care. A patient can be recovered from the acute pain. In the chronic pain is long lasting more than 3 months. The pain is consisting continuously more than the 3 months, that we can say that it is a chronic pain. The people do not have relief through the conservative treatment and suffer from the chronic pain. They may go for the physiotherapy or some surgical intervention if any kind of a disc herniation or any kind of abnormalities found in the further MRI or X-ray. Now, the special test for the neck pain. Neck pain may be because of any kind of a soft tissue structure, malalignment of the cervical spine due to some abnormal posture, due to some kind of a abnormal growth in the cervical region, that may cause neck pain. How we can examine? So first we will go through the Edson test. What is the Edson test and how it helps to diagnose the cervical or neck pain? Edson test, first thing is that it indicates the occlusion in the subclavian artery, right? Subclavian artery, vertebral artery and subclavian artery, which supplies the vertebral bodies or vertebral area of the cervical spine, right? So any occlusion in the subclavian artery, any kind of like thoracic outlet syndrome or extra rib is there, then we can easily find out by the help of Edson test, right? So in the Edson test, what a therapist or clinician is doing, a clinician is, the patient position is in the sitting position. The therapist or clinician will uh, uh, keep his patient's hand, feel the radial pulse, along with the radial pulse, abducting along the, feel the radial pulse. I cannot take any volunteers with me because of some social distancing problem. So uh, either I was thinking before presenting this topic, I will have a volunteer. By the help of volunteer, we can give you a live demonstration. But due to some emergency, due to some problem, that was not possible. So I can demonstrate by myself only. So Edson test, how we can perform the Edson test. Patient is in the sitting position or standing position. Both position we can check by palpating or feel the radial pulse, abducting, abducting the shoulder, extending the elbow joint, and externally rotating the arm. And the neck should be turned the same side. While turning the neck on the same side, the pulsation of the radial pulse, the pulsation that may goes down or decreasing, or sometimes that the pulsation may not be felt. That is called as that sign indicates the Edson test is positive. And this sign positive, this is maybe because of the occlusion of the subclavian artery or because of the extra rib. That is also called as extra rib. Because of the extra rib, patients may have some absence of the pulsation. This test is also used for thoracic outlet syndrome also, right? Now the next test is compression test. Compression test, it indicates the nerve root tension or any kind of a radiculopathy. For that, we will examine the patient by the help of compression test. With this test, patient is seated on a chair, and the therapist stand behind the patients and keep the hands over the head. Therapist hand, not the patient. Patient is sitting in a normal position with the sitting position. The therapist will keep the head upward on the skull and press it downwards. The patient may have some kind of a pain or some kind of a referred pain in the arm. it means the test is positive. If patient does not have any kind of a referred pain, then the test is negative, right? Then another test is distraction test. The distraction test, it indicates the nerve root tension or any kind of a radiculopathy. In this test, what the therapist will do, patient, the procedure is, the patient position is the sitting position. The therapist stand behind the patient, and the skull or the head should be keep like this, and just give a little distraction or little release from the compression. If uh, while lifting the head, if patient having some relief, then we can say the tension will disappear. So the distraction test, we can say that it is a positive, right? Now the doorbell test. Doorbell test or doorbell sign. Doorbell is the name which indicates that while pressing the C5, patient is having pain, right? How? First thing, it indicates again the nerve root tension or radicular pain. So deep palpation over the C5 process or C5 vertebral process or C5 segment. If press the C5, if the therapist press the C5, patient is having pain in the shoulder level along with the C5 distribution, right? This is if a patient is having pain or tenderness over, if a patient is having pain or referred pain in the shoulder region or C5 distribution, then the test is positive. So doorbell test is very easy, and we can remember this thing. Doorbell, door means we will press the button. C5 projection, we will press, we will find the pain, or patient will complain the pain. Next is Bacody sign. What is Bacody sign? Bacody sign, it indicates the cervical radiculopathy. In this, the patient's head, in this, the patient raises his or her hand and on the top of the head. Very easy. Bacody sign for the just patient himself can be do this thing. Ask the patient to keep his hand on his head, right? And you can ask the patient whether he is having pain or is he relieves from pain. The patient will say that he has some relief in the pain. This is the Bacody sign. Halsted maneuver. Halsted maneuver is the reverse Adson test. In this, the neurovascular compression, we can find it. In this, the patient is seated, the palpate the radial pulse, and then pull traction. Suddenly, we will give the traction of the patient's arm and downward, or ask the patient to extend his head backward, right? In this test, the same thing we will find. We will find the absence of radial pulsations. Next is Hoffman sign. Hoffman sign, for Hoffman sign is the sign where it is for the myelopathic changes or myelopathic sign. In this, the test Hoffman sign is very easy. You just uh, uh, you just keep a middle finger. Wait a minute. You just keep a middle finger, and you will flicker the middle finger. If you will flick, we can see this is the patient's arm, and you will find, you will keep the middle finger. This is the middle finger. You will just flicker the middle finger. If while flicking the middle finger, if rest of the fingers get flexed, that means the Hoffman test is positive, and some pathology or some kind of a compression over the neck region, because of that, patient may have positive sign of the upper extremity, right? Now, the Jackson compression test. Jackson compression test, it is also for the nerve compression. In this, the patient is sitting and bend the head obliquely backward, and then downward pressure will be applied over the head. So in the ejection compression test, what we will do, the therapist will stand on the behind the patients, and we will turn the head laterally and then press it down. While pressing, if patient is complaining pain in the cervical region or referred from downwards, then the ejection compression test is positive. Remember, the compression test and ejection compression test, these two tests are different, right? Another test is Lermet sign. What is Lermet sign or Lermet sign? Lermet sign, or we can also known as a Barber chair phenomenon. Both the names indicate spinal canal stenosis examination. Right. So for the spinal canal stenosis or multiple sclerosis or any kind of a cervical disc impingement or any kind of a local areas tumor or neoplasm, we can find it by the help of Lermet sign or Barber chair phenomenon. In this, the flexion of the neck producing electric shock or over the and the sensation like extend down to the spine and shoot into the limb also. Right. How we can perform? We will flexing or bending the patient's head forward. Right. We will bending the head forward and down, and the spine will have electric shock kind of pain. That is, if electric shock kind of a pain is positive, that means the Lermet sign or Barber chair phenomena is positive. Another test is Rust sign. Rust sign is for the severe sprain or subluxation of the cervical vertebra. Right. This is this test is positive if patient in this test the patient is holding his head weight, his head weight on the on the head, right, and the lifting the head manually while arising from the lying down. If the patient is doing the same thing while lying down to sitting, the patient is lifting his head, that means some kind of severe sprain or some kind of a subluxation is there. Because of that, patient may not be able to stable the neck region. Ankle clonus. I just added the ankle clonus in this cervical area because we are discussing about the myelopathy also. So ankle clonus may be indicated of the upper motor neuron lesion. Quickly dorsiflex the foot while curling the heel in the palm to relieve the load. So these are all 12 or 13 tests which will help to diagnose or which will help to differentiate from the normal pain, referred pain, or any kind of axial pain or localized pain. Right. Now we will come to the treatment of the neck. So treatment of the neck pain mainly depends on etiology and onset of the condition. Right. The main treatment is to treat underlying either causative treatment. Sometimes we will go in the emergency for the traumatic neck pain. If a patient is having acute traumatic injuries, then we will go for the medical treatment also. So grossly, we will divide it into two parts, like conservative treatment or non-surgical treatment and surgical treatment. In the conservative treatment, it is again divided into four things. That is rest. Rest is one of the good remedy to relieve from pain. Drug therapy, like NSAID, anti-inflammatory analgesics drugs that can be given by the clinicians, by the allopathic practitioners. Physiotherapy plays an important role to relieve from pain, and the important thing is activities of daily living and correction of the life. So rest is the important part for the neck pain, as I already told. It depends the duration of the pain and how much the duration of the pain. According to that, we will advise the patients to go for the rest. For prognosis and causative factors, rest is for proper positioning with the neck while seeing the therapist or physicians. During the rest, we will advise some orthosis also. We will advise some home remedy also. We will advise some home treatment plan also. Drug therapy, as I already discussed, these are analgesics and NSAID, and some kind of injection that can be given by the clinician, or that can be given by the allopathic practitioner, not us especially. So our main thing is physiotherapy. How physiotherapy relieves from neck pain. So as we have discussed, and the pain, acute stage, subacute stage, or chronic stage. These three stages are there. Acute stage, after having some injury or after having some sprain or strain in the cervical region, we can introduce the cryotherapy or icing. But remember this thing, that it should not be placed directly over the lateral side of the neck, because here we have a carotid arteries, and we have a very soft tissue structure that cannot be uh, introduced by the icing, right? So icing in the acute stage, as we all know, that acute stage is from 0 day to up to 7th day. In this duration, we can go for the cryotherapy and rest. Next thing is subacute stage. Subacute stage, after a week, we can go for the moist heat or a kind of a contrast bath. For in the subacute stage, we can continue the moist heat and contrast bath. Contrast bath consists of two things, that is hot and cold compression, right? 5 minutes like hot or moist heat we can apply, and 3 minutes we can go for the cold compression in the subacute stage. Subacute stage, that can be can say around from the first week, start of the second week to third week, end of the third week. In the chronic stage, hot compression therapy can be introduced to the patient. Now, some electrotherapy plays an important role to relieve from neck pain. Start with the superficial modalities. Superficial modalities like infrared radiation. In the infrared radiation, the infrared bulb is a kind of a superficial modalities that can be introduced just 10 to 15 inches, 10 to 15 inches uh, uh, away from the neck region. Especially, we have to remember this thing, that it should be focused on the localized tenderness tender areas on the posterior side of the neck. It should not be directly blowing over the eyes, right? Now, deep thermal modalities. In the deep thermal modalities, we can introduce microwave diathermy, shortwave diathermy, and ultrasonic therapy, right? They all increases the local circulation of the blood. They all are excrete the kind of a endorphin, which is also a natural pain relief, right? Then pain modulation. In the pain modulation, we can go for the TENS therapy and IFT, but the TENS therapy cannot be directly applied over the lateral side or anterior side of the neck region, because TENS therapy may cause some kind of TENS therapy is a dangerous in the anterior side or lateral side of the neck. TENS and IFT, these are all like medium frequency current and low frequency current. TENS therapy is a kind of a channel electrode that can be introduced to the neck regions. The electrical impulses is producing by the electrical impulses producing the local endorphin is excreted, or because of the local endorphin excreted, the pain gets relieved. IFT or TENS is working on the Pengate theory also. As everybody knows, the Pengate theory. Then laser. What the laser? Laser is also a pain relief kind of therapy. It increases the nerve sensitivity and decreasing the bradykinin level. It normalizes the ion channel and release the endorphin and enkephalin that produces the analgesic effect. Right. Now, next we will go for the exercises. Exercises especially for the neck strengthening exercises, different exercises that can be performed according to the conditions. So isometric exercises can be given for the strengthening exercises. We can apply the resistance exercises, neck mobilizing exercises, neck ROM exercises. Neck ROM exercises that helps to increase the range of motion. So many kind of a condition that can have a stiffness or reduce neck movement. So neck mobilization exercises is helpful either actively or passively. Now manual therapy, manual mobilization technique, it should be by the expert, not for anyone. Myofascial release, myofascial release. In the myofascial release, release the trapezius muscle spasm, release the sometimes because of the neck pain, because of the cervical headache, myofascial release plays an important role. CBR, craniovertebral craniobasilar release is helpful for relieving from the tension of the muscles. MET, muscle energy techniques, helps to relieve from local muscle spasm or muscle tension. Neck manipulation technique, it should be by the experts, not to be used in the newly physios. Now cervical traction. Cervical traction, before giving the cervical traction, we have to examine properly. We have to see the X-ray, a radiograph, and we will find is there any kind of complication in the neck region, then we should avoid the traction. And everybody knows, I hope everybody knows that traction, cervical traction is to be given 1/7 of the body weight if advised or if needed. Now, along with all these conservative treatment and physiotherapy, we can advise the cervical collars, normal cervical collars, the soft cervical collar that can be used while driving or while moving from one place to another place. Halter collars or Philadelphia collar that can be given in the case of disc or in the case of herniation of the disc or any kind of a severe injury. It's any kind of orthosis of the cervical spine, not to be used in a long period of time or in a 24 hours duration, but the halo cervical traction brace is advisable for a longer period of time. The halo cervical traction brace is to be given for the longer period of time to heal the local area. Either any kind of a severe cervical injuries, any kind of whiplash injury. Whiplash injury that everybody knows, any sudden flow and backward movement. Because of that, patient may have this whiplash injury. This is most common in the car accidents. So in that condition or instability of the spine, and that in these conditions, we can advise the halo cervical traction brace. The halo cervical traction brace is kind of a brace which supports from the thoracic region to the skull or to the entire head, right? It has a two like bar, parallel bar, and it fixed a round circle over the head. It restricts the motion of the neck, like flexion, extension, lateral rotation, or side flexion. All the motions can be restricted in the halocervical traction. Next is contour type of pillow. Contour type of pillow, as the patient is having pain, neck pain, or some local pain is there because of the curvature lost, then we can advise the contour type of pillow. And the another orthosis that can be used according to the patient need. Now, we have to improve the activities of daily living of that particular patient. Everyone has have pain in the neck nowadays, as I have discussed, because of our daily routine, because of we are in the digital world. Since last 4 months, we are all dependent on the online process, like teaching, like doing job, like doing some work on the laptop or the mobile. We are all are having some bad habits nowadays. So everyone has to be do regular exercises. Regular exercises includes our neck muscle exercises, some strengthening exercises, some active movements on the neck to maintain the range of motion. Everyone has to do in a routine way. But if a person is having pain, if a person is having a clinical symptoms, or if a person is having a kind of a radiculopathy, then uh, we have to plan a protocol for that particular person, because all the exercise is not good for all the individuals. Next is proper lying. We have to lie properly. If our bed is not proper, if our pillow is very high or very low, then the pain may occur in the neck region. Sitting and working. Sitting, like our sitting is not proper, then pain may persist in the neck region. Our area of working should be proper. In the ergonomics lectures, I hope you all attended the ergonomics lecture under the banner of Physio Inculcator. You might be knowing about the alignment or biomechanics of the spine, or good posture or bad posture. To maintain the proper body alignment, for maintaining the proper body alignment, we can relieve from the pain to maintain appropriate ergonomics, as I have discussed. And other activities of daily living, like sitting, like lying down, like driving a car. Everywhere we have to keep our neck in a normal posture, right? This is the one picture which I can see. I can share with you people. This is the normal cervical spine posture, and this is the sitting area, where you can find out your neck portion is properly aligned and the proper ergonomic position is there. The person is sitting in front of the computer or laptop and is doing his job. While doing the job in front of the computer or any kind of device, if your job is a prolonged sitting job, in between the lecture, in between the 1 hour duration or 2 hour of duration, we have to take 5 minutes of nap to do some exercises, some free range of movement exercises to relieve from tension of the postural muscles in the cervical region. Some surgical procedures are there. If a person is not relieved from pain, or a patient, if a patient is having some severe compression on the nerve, some kind of disc herniation, then we will advise patient to go for the neurosurgical opinion. And in the neurosurgical opinion, I will not give you more detail about this, because this is not our domain. So the procedures what the surgeons are doing, dissectomy. Dissectomy means with or without fusion. In this, the surgeon removes herniated disc and material that is pressing on a nerve root or the spinal cord. If any kind of a disc herniation is there, because of the disc herniation, any compression in the nerve roots or spinal cord, then the surgeons can go for the dissectomy. Next one is cervical spinal fusion. Cervical spinal fusion. In this, the joints gets fused together. Two joints gets fused in the cervical spinal fusion to relieve from pain, and the disc can be removed. A spinal decompression. Spinal decompression is the procedure. In this, the pressure is reduced on the spinal cord or nerves by removing the part of the bone or disc. These all three are more or less same according to me, because I am not a surgeon. So I can tell you these three things can be done by the neurosurgeon or orthopedician, because nowadays orthopedician are having expertise to do these are all things. Surgical procedure, another surgical procedure like artificial disc replacement, percutaneous radiofrequency neurotomy, not neuroanatomy. These are all procedure can be done by the neurosurgeons if a patient does not relieve from pain. Before the surgery, therapist plays an important role. After the surgery, again therapist plays an important role. So it is so much important and skillful than the conservative stage of physiotherapy. If we will manage in conservative manner before surgery, then we will we will save the person's surgery. We will save the patient's operative procedures. Treatment according to post-operative complaints and complication. We will advise the treatment. We will decide the treatment, what kind of a treatment and what is to be used, and uh, what kind of a protocol is to be used for different kind of a cases. In general, physiotherapy, post-operative physiotherapy is to nowadays in Bhopal also, the legend or the famous neurosurgeons, they are very well known about the physiotherapy responses and results. So that in the today's scenario, I will not discuss about the previous scenario. In the today's scenario, the surgeons are like keep us physios like a team. Before surgery, they will give us a responsibility to treat a patient. After surgery, they will all again hand over the patient with the faith that you are the physiotherapist. You can treat the patient. My work is only surgery that I have been completed. I have been done in an hour. Now the patient is over to you. Yes, this one word gives a responsibility to relieve a patient and to give our maximum to the patient. Thank you so much. Thank you so much, everyone, to listening patiently. And I will ask to Dr. Himanshu sir. Dr. Himanshu Sharma sir.
Hello. Yes, sir.
Yes, sir.
Sir, thank you, sir.
Sir.
Thanks. Yes, sir. Thanks a lot, sir, for such a wonderful session. And we had a great learning ahead in this session. You have so much wonderfully explained all the areas of the cervical pain, its differential diagnosis, management, even the categorized management in a well-planned way. So we are really grateful to you, for sir, for explaining each and every aspect of the cervical pain dysfunction, its management. So really thankful to you, sir. Now, if you allow, sir, can we go ahead for the question answer if someone has any queries?
Sir, definitely. I would like to, I will try from my level best to relieve their queries to give their answers.
Thank you, sir. Thanks a lot. As most of the things you have already covered in very detailed way, still there are a few queries. There's one question from Dr. Pratik Agrawal, sir. Sir, we can't use tench or entry a part of neck. What are the possible side effects? I think it is the very common question.
Yes, yes. Tents cannot be used in the neck area because
Anterior neck, yeah.
the anterior neck area. Because in the anterior neck, as we all know, that in the anterior side we have the carotid arteries. In the carotid arteries, if the pulsation is there, any kind of any plaques is there, then they may get dislodged and they can cause kind of some kind of a hemorrhagic infarct in the brain that can be a serious issue for the patient.
Thank you, sir. Thanks a lot for great explanation. Now, there's one more question, sir. What makes swimmer's view different from the lateral view?
Right. Swimmer's view. As I have told you, I want to go in the swimmer's view slide. This is the swimmer's view. In the swimmer's view, we can ask the patient or a radiologist. We will advise the patient to especially take the swimmer's view. In the swimmer's view, we can take the X-ray while extending, or a little bit flexing the neck. In this position, we can easily find this thing, the C7 and T1 vertebra. If anything is there or any kind of abnormality or any kind of a pathology is there, then it can be seen easily in the swimmer's. That's why we will advise to go for the swimmer's.
Thank you, sir. Thanks a lot. and we are really blessed to have many senior faculty members who has joined us for this great session today. And we are really grateful to all the senior faculty members, academicians, my own teachers, Dr. Harsh, Dr. Charu Sharma ma'am, Ritu ma'am, that they are continuously supporting and blessing us for these events endeavor. And there are few many other senior physical therapists also joined us. Dr. Kalpana Jutsi ma'am has joined us. She is associate professor at the Jamia Amdard University, Delhi. Dr. Jiten Munjal sir is also a senior physical therapist at the North DMC Medical College, Delhi. And one senior physical therapist from Saudi Arabia, Dr. Amita Anup Sharma ma'am has also joined us. My own teacher, Dr. Charu Sharma, has joined us from the Washington along the way. And there are few many participants who has joined us overseas from the Pakistan as well as from the Bangladesh. So we are really grateful to you all for joining us for this great session. And there is one question from Jiten Munjal sir. Sir, first of all, greetings to you, sir. It was a wonderful and lovely session. And now, sir, they want to ask that can you suggest appropriate pillow and type of normal person? Appropriate
Right.
pillow and type for a normal person.
For the normal person, as we advise in the routine ways, sir, Jitendra sir, we are advising a soft cervical pillow. But if we will advise a contour pillow is a kind of a pillow that can be maintain our neck neck posture or neck lordosis properly. So contour pillow is a kind of a pillow in which flat surface is there, and I can give you the explanation. This is a kind of a plain surface. On here some projection is there. Projection helps to maintain our curvature of the cervical spine. So in routine life we can advise the contour pillow for that normal individual.
Thank you, sir. Thanks a lot for a great explanation. There is one more question that, sir, for how much long one should be recommended to wear a cervical collar in case of cervical spondylosis, and what is the better rest or mobilization? So, what would be the better recommendation from your side? Either the patient should take the rest or should have some mobilization during the acute phase.
I'm sorry, Dr. Himanshu sir. Initial, your voice was cut.
Yes, yes, sir.
Because of,
Sir,
please repeat.
yes, please, sir. Sir, there is a question that if what should be recommended to a person to wear cervical collar? For how long the patient has to wear the cervical collar? And another part of the question is that if it is the case of cervical spondylosis, what is better, rest or mobilization, especially in the acute phase?
Right. Thank you so much for asking the question. It is very nice question. First thing is that, oh, how long we can wear the cervical collar? Cervical collar is only for the purpose to mobilize the neck while moving from one place to another place, like road side driving, like traveling from one place to another place, or while doing some kind of exertional activities. That time we can wear the cervical collar. While resting time, we have to remove the cervical collar and remove the cervical collar. Second thing, in the case of acute spondylosis, what can, sir, please, second part of the question is?
Yes, sir. Yes, sir. The second part of question is there. In acute case of cervical spondylosis, what do you recommend? Rest or mobilization?
Right.
Especially acute phase.
Rest, especially acute phase. Yes, thank you for repeating the question. In the acute phase, our first thing is that rest is one of the good remedy to relieve any kind of a pain. So rest is not that kind of a thing. We have to advise the patient just go and lie down on the bed. No, rest is a common terminology. According to the patient condition, we have to advise rest as as much as possible. You have to take the rest, like you have to relieve from pain while not taking over exertional movement. This is a kind of a rest we have to advise in the acute phase. We will not restrict their activities of daily living, but we will restrict their exertional movement. Rest is the one part, and another part, we will advise to go for the physiotherapy. We'll go for the icing, and icing is to relieve from pain in the acute phase.
Thank you, sir. Thanks a lot for a great explanation. And sir, there is one more question from Jebun Nissa. I think she's from Pakistan, and she want to ask that can you please give a brief idea about the neck spasm? What to do in the neck spasm?
Yes, in the neck spasm due to some overstress injury, neck spasm due to sudden turning the injury, neck spasm due to some overstress. Because of that, patient may have pain, or a patient may have a sudden spasm in the neck. In the condition of neck muscle spasm, we have to go for the first thing is in the acute condition, as discussed, icing, or in the subacute or chronic condition, compression therapy or hot compression therapy or contrast. Along with that, we can go for the stretching exercises. But stretching exercises, we have to especially advise while seeing the patient. If a patient is having kind of a neck spasm, then we can go for the MET technique. MET technique is muscle energy technique. We will utilize that particular energy to that particular area, and we can relieve the patient easily. The neck muscle spasm, we can give some stretch to movement, hold it for few seconds, like 10 seconds, then again release it. This should be applied 3 to 4 times in a same session, and it can be advised 3 times in a day.
Thank you, sir. Thanks a lot for clearing all the doubts of the participants. And we had a good interaction. Means the participants were carefully listening the session. And it was really a very knowledgeable session. And we had all areas of the cervical spine assessment and management. And at last, there is one last query, if you allow. Sir.
Sir, please.
Yeah. So the Arpan want to ask that is traction better for neck pain?
Yeah. Dr. Arpan, traction, manual and mechanical, these two kind of a traction which we are using in a routine practice. Manual and mechanical. Manual traction means by the help of our hands, the therapist hand, we can just release that particular neck tension. And the mechanical traction by the help of electrical device, we will advise the traction. But the thing is that in which condition we are dealing with the traction. If a patient is having some kind of a risk space reduction, then we can give the cervical traction. But along with that, if patient is having stenosis problem, if a patient is having some osteophytes or some disalignment of the cervical curvature, then we have to avoid the cervical traction.
Thank you, sir. Thanks a lot for explaining and clearing all the doubts of the participants. We are really grateful to you for sparing your precious time to share your incredible knowledge with us, despite of having a very busy schedule, because you are also accredited with various hospitals in the Bhopal. So you are having so much busy schedule, and still you have find the time to share the knowledge with us. And we are also grateful to all our previous resource person for this particular platform. We are also grateful to them for their always continuous support, as Dr. Mathidat Sharma and Dr. Abhishek Chadar has also joined us. So thanking you all. Thanks to all the participants who has joined us over the seas and shown the faith on us, and we'll keep trying delivering some informative talks and session on the physiotherapy. Thanking you all. Again, heartiest thanks to you.
Thank you
From the core of my heart, Jagdish sir. And at the last, there is information that tomorrow again we'll have a session on the same time at 9 p.m. So please be in touch. Stay tuned, stay safe, and take care. Good night. Thank you, sir.
so much. Namaste.
Thanks a lot, sir.
Namaste everyone.
Namaste.
Thank you.